MRI, magnetic resonance imaging. Pioneering work in physics done between 1666 and 1945 led to the detection of nuclear magnetic resonance (NMR) signals in liquids and solids emitted by magnetically labeled nuclei. The hydrogen nuclei constituting the various structures of body present in the water molecules, fat molecules or macromolecules, with or without contrast agents, are placed in a powerful magnetic field generated by a superconductor solenoid. On being placed in this external magnetic field, the protons enter the excitation and relaxation phase, thus emitting NMR signals, which are processed to form a magnetic resonance image. MRI assesses the body in different axes, thus producing axial, coronal, and sagittal sections. The lack of ionizing radiation exposure and a higher soft tissue contrast makes MRI the preferred modality for assessing ocular and orbital anatomy and pathology. The emitted signals depend on the concentration of nuclei in that region and the relaxation properties of nuclei characterized by T1 and T2 relaxation times. Before the detailed analysis of pathologies, it is essential to understand the basic anatomy of the orbital structures and their visualization on MRI scans. Orbital tissue characteristics on MRI of major structures in the orbit are as follows. Aqueous, vitreous, and CSF look hypo-intense on T1 and hyper-intense on T2. Lens shows intermediate signal intensity on T1 and T2. Sclera, choroid, and retina, all the codes appear as one signal, intermediate signal on T1 and hypo-intense on T2. Extraocular muscles have intermediate intensity on T1 and T2 but enhance with contrast on T1. Optic nerve has signals similar to intensity as cerebral white matter on T1 and T2 with no contrast enhancement. Optic nerve sheath contains CSF, hence hypointense on T1 and hyperintense on T2. Orbital fat appears hyperintense on T1 and intermediate on T2 and becomes dark on fat-suppressed images. Lacrimal gland shows intermediate signals as grey matter on T1 and T2 and has mottled appearance of reduced intensity with enhancement with contrast. The location of orbital structures is best understood by dividing them in different compartments. Intraconal space. It is the space surrounded by the four recti and intermuscular connections, housing the optic nerve and its sheath, seen best on axial view along with add-on coronal views. Extraconal space. Best visualized in coronal sections, this is the space between the muscle cone and the periosteum of the orbital wall and anteriorly limited by the orbital septum. Subperiosteal space. It is the space between the periosteum and the bony orbital wall, which requires all sections for optimal analysis. Extraocular muscles. Enlargement of the muscles, involvement of the tendon and muscle belly is seen best on quasi-coronal sections and axial views. Lacrimal gland, seen best in axial and coronal sections. Ocular structures, seen best with both coronal and axial sections put together. Preseptal space, it is a space in between the orbital septum and upper and lower eyelids, seen best with a combination of coronal and axial views. As clinico-radiological correlation is mandatory to understand, let's discuss some of the major pathologies that we come across for a deeper and better understanding. Here is a 34-year-old male with right eye axial proptosis and disc edema and choroidal folds. On MRI, a well-defined intraconal mass causing right-sided proptosis was seen, causing compression on and displacement of optic nerve superinasally. It shows heterogeneous hyperintense signals on T2 and isointense on T1 weighted images with homogeneous post-contrast enhancement with no vascular flow voids within the lesion. It was diagnosed to be a cavernous hemangioma, followed by complete surgical excision. Here is a 34-year-old male with only light perception in the left eye, axial proptosis, restriction of ocular movements in all cases, retrobulbar resistance, palpable form tender mass inferomedially and choroidal folds. MRI showed an ill-defined lesion, hypointense on T2 and ISO to hypointense on T1 in the intraconal plane with focal extension into the extraconal plane along the superolateral and inferolateral aspects. Globe distortion and optic nerve compression was present, and the lesion extended posteriorly across the inferior orbital fissure, inferiorly along the left carotid canal up to C2. Similar T2 hypointense lesion involving the dura was seen extending into the left cavernous sinus and the infratemporal fossa. He was diagnosed to have idiopathic orbital inflammation, that is, IgG4 related disease, and responded well on being treated with IV methylprednisolone. MRI is indicated in the following: inflammatory pathologies like thyroid orbitopathy, orbital cellulitis, non-specific orbital inflammation, collagen vascular disease, lymphoproliferative diseases, and fulminant neoplasms. Neoplastic pathologies include all the cases ranging from benign to malignant, occurring in various spaces of orbit. Structural pathologies include traumatic disorders, congenital facial deformities, cysts like implantation cyst, dermoid, lacrimal cyst, and mucocele. Vascular malformations and vascular tumors are best visualized on MRI. MRI is also used for degenerations and depositions like progressive myopathy, amyloid deposition, and scleroderma. Dynamic MRI imaging can be used for acquiring time series of images to demonstrate abnormalities of ocular motility and differential enhancement in mass lesions. Recent developments in technology, including orbital surface coils, fat suppression techniques, fast gradient echo pulse sequences, MR contrast agents, has provided a spatial and contrast resolution with direct multiplanar imaging, enabling us to study the lesions and surrounding structures extensively. MRI provides ophthalmologists with qualitative and quantitative information of various pathologies. Evolution is the secret for the next step, and a comprehensive understanding of MRI analysis makes the ophthalmologists independent and aids in clinico-radiological correlation preoperatively and intraoperatively. A prompt post-operative histopathological correlation adds to our continued learning and understanding of the different pathologies and promotes transformation into better meticulous surgeons, because every success story is a tale of constant adaptation, revision, and change.